presented. Okay. Annie, let's get you mic'd up. All right, and for our final talk, and what I would say is everyone was asked to give several talks who came. Dr. Annie Usisiwe Madalitso Alanese, who is from Malawi, and is a board certified gynecologic oncologist at Houston Methodist Hospital System in Texas, is going to be our keynote speaker. And so her talk is going to be a little bit longer. It's the one talk that she was brought here to give to all of us. Dr. Alanese has been to Alaska probably 8 or 9 times now. She's been deeply involved in our gynecologic oncology and Let Everyone Know activities. She's done the Alaska Climathon twice. This is her 3rd time involved as a speaker at Let Everyone Know's Arts of Healing Weekend. She's been the keynote speaker for Alaska Medical Missions, and has been here in Alaska fundraising and building the Alaska-Malawi connection for many years, because one of her best friends from medical school is an emergency room doctor here. And that sort of started the process of her connection here in Anchorage. Our very own Dr. Burke went to Malawi and volunteered where he met Dr. Alanese. And then when he came back to Anchorage, he pulled me aside and he told me that you have got to meet this doctor, because trust me when I tell you, you two are peas in a pod. And he was not lying. When Annie and I met, I heard her giving a talk, and then subsequently tried to recruit her up here to talk or Let Everyone Know conference, which she did right before COVID hit. And then from there, I brought Ari to Malawi, and the friendship was born. So what you're about to hear is her talk on her insights and experiences as a healthcare provider, living in the in-between, the United States and Malawi. And it's such an honor to have you here. Thank you so much for coming. Are you all mic'd up?
Yeah, I guess I am. I didn't even realize that it was already on. Something is off. Okay. All right, that helps. So yeah, so the last time we were here before the world fell apart, what was the name of that bar that we went to that has the bras there? Yeah, Coots. So we went to Coots and we went to that special room, and it was like these beautiful brains of women that are gynecologic oncologists that are publishing papers and practically writing textbooks in their sleep. And we found ourselves in this room with bras discussing whether or not we should add to the collection with our own. And then shortly after COVID happened, and I remember thinking I should have left a bra, so. Anyway, thank you for having me. And so, some of you have probably heard a little bit of my story, but I'll just kind of give, some background and, keep moving forward from there. So I was born in Malawi, the oldest of 8 children. For most people, looking at me where I was growing up in Tonje, I just looked like a young little village girl who probably didn't have much of a future coming in front of her. However, through a series of miracles, I'm finding myself here today, giving you this talk as a United States trained gynecologic oncologist. And so, even when I sit and think about my coolest dreams as a child, this wasn't, one of them. It wasn't actually quite this cool. So for those of you who are wondering the geographic of Malawi location, I always feel like, fun fact, when we say this is where Madonna adopted her babies, somehow the geographical location of Malawi becomes clear to most people. So there it is. So I spent most of my childhood in Tonje, and like most Malawian villages, Tonje was plagued with poverty, disease. I think we're missing slides. I'll have to pause. There we go. And I received most of my primary school education actually under a tree. The most accessible transportation out of, Tonje was usually on feet. On a really good day, you would get a donkey cart or an ox cart or a bicycle taxi. By the time I was 10 years old, I had to be all grown up. I was the oldest. And so, while most mothers want to dream that they will raise their children to adulthood, many mothers of childbearing age die in childbirth. So it was really imperative for my mom to make sure by the time I was 10 years old, I knew the responsibilities of being a mother. So by the time I was 10, I knew how to take care of a baby. I knew how to go to the market and shop for the family. I knew how to make meals, and this is a reality for many young kids, growing up in Malawi. An example of this is Mary and Timothy. About 5 years ago, Mary was 13 years old. She pretty much had walked from her village to a little clinic where her mother used to get care. She actually went there to return the HIV medications that her mom had been taking because she had passed away from complications of HIV. And she brought with her the little brother that she was now raising, Timothy. When they got there, they actually realized that Timothy had very severe, malaria. And generally that causes, red blood cells to be destroyed. So he was also very severely anemic. And so they ended up getting admitted to the clinic. They were taking care of Timothy medically, and Mary pretty much was doing all the bedside care. Most hospitals don't provide food, so whatever food that she could gather up, often she would let Timothy eat first before, even if it meant that she would go hungry. And at some point, the clinical officers became aware that these kids were essentially by themselves. There wasn't anybody to take care of them. Mary, had a vertical transmission of HIV. So, between that and her mother's diagnosis, nobody really wanted to take care of them. And through some contacts with some missionary friends, doctors that were working at that facility, they were able to actually get Mary and Timothy to our facility now in Salima. So, those are the true stories. So much of my life, in Tonje was full of struggles like that. Even clean water was a luxury. Most of the places where we got water, cows were drinking from there, goats and dogs. And then when sometimes the rains would fall, we would literally dig through the sand until some water, would come up, and then would put it in the buckets and carry it in our heads. Sometimes when I take my very American children, to the beach here, it's always sobering to watch them because they would do the same things I did when I was their age, but they're just digging in the sand to find water for the fun of it. And often when droughts would come, it would come with concerns. These are agricultural societies. So if it doesn't rain, there's no food. And I remember trucks would come to our village on some of our worst droughts when, the rains would fail. I think it's the next slide. Yeah. And we would usually know, at the time it didn't have much meaning. Now that I've been here, there were these bags of corn that had red, white, and blue colors on them. And we knew it wasn't corn from our country because it was yellow. And usually our corn there looks a little bit more like Harmony. But despite the fact that it was different, it tasted different. We didn't even actually like the way that it tasted. But when you don't have food, taste is actually not a priority anymore. So we would stand in these long lines where people would be distributing food. And there were times when you would see that the food is running out, and there'll be mothers with babies on their back, and you would see them start to get desperate because they know that things are running low, and they'll be running to the front of the line and just sort of like begging if there was anything little that they could take back, to their families. There were moments like that when I'll be standing in those lines that I would always wonder if the rest of the world actually knew that there were still people in Tonje, because often you would feel like you sort of lived in this part of the world that was somewhat forgotten and unknown to everybody else. My dad was a trained clinical officer. He had an education. Most people that had education, lived, in the city. That's where more access was available. There were cars, there were more modern, amenities. And it never really made sense to me why my dad always chose what I thought was the road less traveled, because I would have preferred to be in this city than this life that I was growing. He was also a pastor, and so this was all embedded in his beliefs. So this is exactly the place where he felt that God had called him. This is a population of people that he felt that he needed to serve, but we also had to live that life. I did bless that comment with him by telling them that I would, refuse any marriage proposals from men that were going to become pastors. At age 14, I was actually the first student out of my village who actually was, selected after I took my 8th grade exam to go to secondary school at Blantyre Secondary School. So everybody was really proud because I was going to this big city, to one of the top schools in the country. I packed my little cardboard suitcase at the time. I had a uniform, 3 outfits, and it was the first time I actually had a pair of leather shoes. And so I reached Blantyre Secondary School, and very quickly when I got there, it was, I felt like I didn't belong. There were several of the kids that were dropped off in cars, and I'd pretty much gotten off the bus and like walked onto the campus. And so I felt like I was a misfit. And in fact, I was a little bit embarrassed about where I was coming from. And often I wouldn't actually share what my background is and where I was actually from. So, people would ask me, where are you from? I would say Salima because it was vague enough. Because if I was actually clear to the small village that I came from, then people would really realize how dire the situation that I came from was. So I would often feel alone there, but I also knew that this was my only chance to actually make it out. So in 1994, Donna Ivy was an ER doctor from a very tiny town called Poville, Texas. Actually, the next town after that is called Boonesville, Texas. So she came there for a short-term medical mission trip. And while she was there, she was able to see firsthand, what the lack of well-trained medical personnel was and the crowded, hospitals. And she realized that what she had at her disposal was that she couldn't fix anything completely in 2 weeks. But what she could do is to give something that would keep giving. So she felt, she had money and she had a country that had opportunities for education. And then she met a young girl, me, who had dreams of becoming a doctor, but unlikely in the situation that I was living in. So she used what was in her hands and decided to give me a full scholarship to the United States. So on July 4th, 1994, I actually landed at Dallas Fort Worth Airport with a full scholarship to attend college with Donna Ivy, covering the cost of that. It was an out-of-body experience for me, when I arrived. I had just come from Africa, the Black continent, where I pretty matched up with everybody. And for the first time, I walked out of the airport and there were so many white people. I actually had never seen that many white people. I went to a church that had 2,000 people and I was the only Black person there. It was the first time that people would be like, where's Annie? And they'll be like, she's right there, with the 2,000 people in there. I remember going to Walmart for the first time. I mean, that was a phenomenon, like there was everything you could possibly wanted at Walmart and everything you didn't even think you wanted. And it was available, and like entire stores that were like built and dedicated to pets. That was like, unreal, to me. I went to a Sunday school class that Donna took me to. It was women that were learning, they were wanting to lose weight. And the strategy for losing weight was going to be to learn to eat only when you're hungry. And so I was sitting in this room and there were like grown women, like describing the first time they had actually felt the symptom of hunger. And you can imagine for me at 16, sort of like wondering, how does somebody get to the age of 50 and never felt hungry when my entire life for 16 years, I had had the feeling of hunger. And so I definitely knew I wasn't in Kansas anymore. This was a completely different world. After my first year of college, I decided to go back to Malawi to visit my family. And my life had drastically changed. And I remember as the plane was landing in Lilongwe and I was looking down, it was such a different appearance from what I had seen at DFW. There were all these scattered dirt loads, very small huts, and just very large open fields, which was so different from the high rises and the overpass, highways, that I had seen as I was landing at DFW airport. While I was at home, I decided to go watch my dad working in the clinic, and I became acutely aware of how little he had to treat people who were so severely ill. I saw a very, young, healthy little girl who had a bout of diarrhea a few days, and the mother had to walk a very long way to come to the clinic, and the little girl was severely dehydrated. The clinic had no IV fluids, and she was too sick to drink, and they couldn't access any sort of IV lines. And I remember, sitting there getting desperate. I was texting my American mom to try to think if there was any way for us to hydrate the child. She was telling me, oh, if you have a way to put an NG tube, you can just put the fluids through there. Well, we didn't have an NG tube. Or maybe you can use an interosseous needle and get access that way. Well, we didn't have that either. And then, as the desperation set in, I was literally watching this little girl die. And the hardest part was watching my dad then take the baby and like, strap her, on the back of the mom. And then I'm realizing that this mother now has to make a 15-mile trip back home, basically carrying a baby on her back, who had passed away. Then I went to the district hospital and there were women laying on trash bags on the floor, delivering their babies. And I looked at the corner, there was actually a woman holding a baby and she was just hemorrhaging on the floor. They were so overcrowded, under-resourced, and people hadn't even noticed that there was like a trail of blood, running from her. And I think, it was in those moments, it was sort of like my epiphany where I started to realize that that little girl that went home dead could have as well been me, because I was growing up exactly that life. And that these women that were laying on the floor having their babies and hemorrhaging and dying through childbirth were basically the life that was meant to be mine. So while I was facing this devastating reality, I was also realizing that my life had changed in the United States and I needed to start looking for a greater purpose for why I was there. So I'm going to go back now and just kind of look at some, facts about maternal and healthcare status in Malawi. There's this slide that I have here that sort of looks at some of the differences in the populations in terms of life expectancy. I think the parts that I always find really interesting, median age in Malawi is like 16. And so you're looking at 70% of the population being under 30. So that tells you like most people are not living very long. There are a lot of, young families that are leaving young children. Median age here is like 34, same thing with Texas. And then also you can look at the differences in maternal mortality rate. I did find it very fascinating when you also look at some of the differences even here in Alaska, in terms of the population risk factors. And 74% of Malawians are living under poverty line. That's 11% here and 17% in Texas. So, there are estimated over 300,000 women that die in pregnancy, and 99% of those are happening in low-income countries, and the majority of those in sub-Saharan Africa. So trying to, prevent the most, preventable causes was really what the target was, to look at how we're going to combat this. And so, some of the causes are postpartum hemorrhage, infections, hypertensive disorders, and just really no access. So women are 51% of the population in Malawi, 45% are in their reproductive age, and that's usually between, 19 to 49. 29% of the pregnancies actually are adolescents. I remember once somebody asking me, what do I think about the phrase that says, poverty is sexist? And what came to mind is that, during the times of lacking, children and women tend to be the dispensable sort of population, right? The men are going to go out and work, and, in our context. And so, if there's food to be given, then the fathers and husbands would eat because they have to wake up the next day to go work. And then that means the mothers and the babies will be the ones that would go without food. So young girls would be married off because that would be one less mouth to feed. So in the 1990s, when they were actually working on sort of decreasing the maternal mortality issues, they focused on trying to get women into facilities because most of the deliveries were happening at home, and that's where most of the death was happening. But then now what's interesting is that we're seeing that other than issues of seeking care, women are actually making it to the hospitals, which is where your type 3 delays are happening, because now most of the deliveries are actually happening in hospitals. But we're realizing that why are we not making bigger strides in lowering that? And that's because even when they get to the facilities, now you have a whole set of issues that are happening within hospitals that are telling us that there's more work that we need to do other than get the women to the hospital. So, some of the delays that we see, especially with type 1, those are like economic issues. When people have to travel, often they have to decide if they're going to spend money to get to a hospital, like how sick am I? Is it worth it for me to sell a goat and chickens, to be able to make it to the hospital? So usually by the time they're coming to the hospital, they are very, very sick. Sometimes people just don't know what the danger signs are. And sometimes they've had just, negative experiences in the hospital, and they just feel like they're better off at home being taken care of by their families. Here's a story of, an economic issue. So this is Naomi, one of the kids that actually lives at our facility. Naomi's mom was actually pregnant with twins. She went into labor. Her husband had died, so she tried to stay home with the other kids for as long as she could. And then while she was in labor, decided to start walking with a group of her friends so she could actually deliver in a facility. But on her way there, she ended up, realizing that the babies were coming. So her friends, took her into the field, and she subsequently delivered Naomi, and then had a postpartum hemorrhage and didn't get to deliver the second baby. Her friends basically just wrapped around, Naomi in a cloth and brought her to, our facility for us to take her in. And this was just simply because there wasn't a way for her to just pick up the phone and call 911 and she'll be picked up. They later on had to go back to the village and actually get people to come back and find her body in the field and take her home to bury her. And that's Naomi now in the corner over there. And then type 2 delays were the ones where, patients have transportation issues, being able to get to the facility. And we can probably look at some of what their options are. Usually for the average people in the village, they're either going to travel by bicycle, or like we talked about, the ox cart. So, so if you really have a true emergency, it can be very difficult to get in. Sometimes you can get a car depending on where people live, especially, and this is all in context of people that are living in a village. It's a completely different experience when you're in the city. So when you actually get to the facility, some of the issues is like there's long waits. Sometimes essential equipment is missing. The personnel is not as skilled, and there's sometimes missed or incorrect diagnosis. That's all part of sort of like a multi-layered nature of a system that is lacking. This is like a birthing baby bag list that women are given of what they're supposed to bring to a facility delivery. And much of this is to make up for the things that are there. So the moms bring a black trash bag because often there's not enough beds. So you lay on the black trash bag. For the deliveries, sometimes they don't have cord clamps, so you just bring strings that they can use. There's a razor blade just in case they don't have blades available. And then the jitenje is basically, like the local cloths that they will use to wrap their babies and then to cover themselves. And then a matchbox, literally after you deliver, you take all the stuff that was on the trash bag, you take it out and you burn it. So often this is what the waiting rooms would look like when people get there. People who camp out for days to get to the front of the line. And usually at night, if they don't make it to the front of the line, they would usually lay there. So that picture actually on the right is at Kamuzu Central Hospital, which is like the major sort of referral center in the city. And this is what their waiting room looked like at night. And these are patients that are very sick and couldn't be taken care of it in the local district hospitals, and they get sent to the city. And for days, they're like just waiting for their turn to make it to the front. And often when you walk around the labor wards, and this is what I'm talking about, you can see this woman I'm checking, down here below. I mean, they're pretty much on the floor, on the trash bags, there's that one bed that actually had a mattress. A lot of the beds there don't even have mattresses. So sometimes it was actually more comfortable to be on the floor. And so this is the operating room. At Salima District, they actually have one operating room, the major one, and then there's a minor one. This is a 560,000 catchment area with basically one minor OR and one major OR. What you're seeing right there is their actual supply room. That is where all of their trays are available, and what you see there is all they actually had. So often when we're doing surgeries, we'll take one of those packs and we'll try to do 4 or 5 cases with just one. And this is usually where our scrub techs come in, right? Because they get to teach us like, this is all you need. That's all you're going to get for this case to make it work. Because, you don't want to actually use all of that, because if an emergency comes and you're doing a scheduled surgery and all your scheduled surgeries use up the equipment, then becomes a problem. And this is Devana, just sort of like, somebody that sought out all the, I'm going to deliver in a facility, but still, suffered greatly. So I'm seeing her here because she had come to see us with a vesicovaginal fistula. But her story is that her first baby, she actually delivered by C-section after a cord prolapse, but she could not get to the facility fast enough because she lives very far. And so the baby was dead by the time she delivered it. On the second baby, she was supposed to have a repeat C-section because she actually got to the facility early enough. But she had prolonged rupture of membranes by the time they were working the process of trying to get her in. Because again, remember, if there's one operating room for 560,000 people, you're not going to walk in and get your C-section right away. And so because of the delays that she had in being able to get her C-section and the infection, her baby was actually born alive, but died 5 days later of neonatal sepsis. And then the third pregnancy, she did the same thing. She knew, so often by the third C-section, they actually do automatic tubal ligations. So she knew that it was imperative that this one would actually go well. So she went to the hospital before she was actually in labor, and she was waiting. And at some point she did start laboring and the OR was overbooked. At some point when she was ready to go, apparently the electricity went out. They didn't have any fuel to fuel the backup generators. Then she labored for 18 hours. And while she labored, she ended up rupturing her uterus beyond repair. Her baby died, and she then suffered the complications of a vesicovaginal fistula. So when I was seeing her here, it was at her post-op visit, where she was essentially, mourning the loss of, not only did I lose 3 babies, I'm now never going to have any. And her husband at this point had left her because she was an outcast who was like leaking and smelling of urine, every single day. And so, some of the misdiagnoses that happen, this is, the twins, triplets, and placenta previa. These girls' babies on this side, we had actually walked in and they wanted us to assess a woman who had been pushing for 4 hours, and this was her 4th pregnancy. And we realized the reasons the babies weren't coming out is because they were in transverse position. And we literally had a handheld ultrasound in like a couple of minutes. This is what we realized. She would have probably pushed until her uterus would have ruptured because she was never going to deliver them vaginally. Morgan was one of our nurses that came with us, and she was helping with the delivery. So the first baby came out and she thought she was done. And then there was a second one and there was a third one, and nobody actually knew the mother was going to have triplets. And then on the last picture, those are 2 of people that I did residency with. This woman was actually scheduled for a normal vaginal delivery. And when we saw her, because she was having some spotting, and they told her it was just because she was late in pregnancy, but actually she had placenta previa. So had she actually gone through with the process of, delivering vaginally, she probably would have hemorrhaged and her baby would have died, and so would she. And then, recently on one of our trips, we got presented with this young woman who was 19 years old, and they had told us that she had been pregnant, but they thought that she had too much fluid or more than one baby. So since we had an ultrasound, they wanted us to evaluate her to see, if she had more than one baby or too much fluid. Turned out that there was no baby and not too much fluid. It was the large ovarian mass, which is what we're removing there. And so, in looking at all this, it's not lost on me that it's truly a miracle that, I was able to live this life, but then, find myself here. And so, again, like I talked about before, then I had to be more aware and start to seek what is the greater purpose for my, existence. So while I was in medical school, a group of friends of mine actually decided to do a little garage sale. And we sold $1,500 of items that we had collected, and then found somebody who gave us like a match to that. So for $3,000, I bought land outside of Salima, which is close to the village where we grew up. I didn't have any money, I didn't have any resources, but I just believed that one day this will be able to create the change that I wanted to see in my country. So 7 years later, the land has now become Potawera, which is a nonprofit humanitarian organization. We have a home-style orphanage with duplex houses that you see there with 120 kids and 12 mamas that we put through school. Over 400 kids that are from the village and the orphanage who wouldn't have access to school are educated there. 63 students we have actually sent off to higher education, and some are actually now working back at our facility. We have a computer lab and a learning center where our kids actually now have access to online lessons in English, actually science and math from the US. We have a program where we're actually teaching tailoring trades to the kids, but also to the community. And then an agricultural program that's providing enough food to feed the kids, as well as the access that's sold. We have the medical clinic that's seeing over 200 patients a day, and a birthing center that has delivered over 500 births since we opened in 2021. Sorry, it was all over the place. That's okay. But I think they got the gist of it. Sewing program, Yes. And the outpatient clinic, all good. And the birthing center. Okay, we're there. So, and then, we have a maize mill where everything that we grow, we actually process there to be able to feed the kids. And then on the horizon is actually our plan to build high school and just to provide more access to higher education. And so I once heard somebody say, developing countries are made up of entrepreneurs. Sorry, this is a special needs program school. Okay. And then, of course, the surgical center is the next project that we'll be talking about that will really enhance. Like we talked about before, there's one operating room in this area, and now we're building a surgical center that will have 4. And so, I once heard somebody say developing countries are made up of entrepreneurs and visionaries who, with social justice and equity, actually have the capacity to be part of the economic development of their countries. I believe that our project in Port Tariwa exists to educate and empower those minds in order to build the capacity within the country. And so, this is how I find myself living between the two worlds, Houston Methodist Hospital in the United States, and then how am I navigating this whole process and what are the experiences that we're having, that I can share with you. So these are the brilliant minds. Like I look at the kids there and, Africa's wealth is actually in the minds of her children. And, I think that if we spend more effort lifting the children and they have all the solutions, to the problems that they're growing up, it's truly the survivor-driven change is going to be the sustainable change. This is Joseph. So he actually wants to be a sound engineer when he grows up. So he found an old radio that basically was broken and basically went through the trash, found some wires. This is like a water jug that they carry water in. He was able to get some speakers from an old car. And then he found a little panel that I don't know if you can see it on the corner. It's like a little solar panel. He put this whole thing together and it actually works. And during recess, this thing is like you're in a club somewhere. I'm not sure that his teachers are thrilled, but I found this absolutely brilliant. And he did that all on his own, no textbooks, nothing. And these are kids that are just naturally brilliant. And imagine if somebody actually, gave him the opportunity to go through an engineering program. I think he'll be incredible. And on the other side, these are a group of guys who had decided they wanted to play pool, but they don't have pool tables. And so they created a pool tables. They've got tomatoes and some fruits, and there they go. They're playing pool. And in our own facility, we've seen just, when you give the kids the lift to what they're capable of doing. Selena was one of our kids in their orphanage. I am extra proud of Selena because she, Malawi is still largely paternalistic, and Selena went to a mechanic school with a bunch of boys, and here she is. She actually is so good. She's our mechanic, and she manages all the cars that work at our facility. And then this is Florida. She was part of the, sewing and tailoring program, and she is doing so well that the last few groups of people that have actually taken, they're always trying to get something made, like their skirts or pants. Actually, Florida has been, doing all that, and you can see some of the products of the things that she's making. And there's Owen. He does all the parasites and disease control for our gardens. And we sent him to school. Emma was, again, an orphaned child who's actually gone through a midwifery technical school, and she's now a midwife, and she's assessing a baby and a mom. Annie is actually a success story out of Alaska. So Tom Burke and his wife, Ricky, through their association with the Children's Village in Mangochi, actually sponsored Annie through school and put her through nursing school. So she's actually a registered nurse who's now the charge nurse for our maternity ward. And so again, that goes to show you that, if you give these kids an opportunity, that they can actually get there. And so, I'm going to go into a little bit of now the dichotomy of living between the US and Malawi. So, this is a story where I was in Malawi not long ago. I got called because there was a woman that had come in and was actually in labor with a 28-week baby. And when I got there, she quickly delivered this small little boy who weighed like 2 pounds. And the only oxygen we actually had available was just like a little nasal cannula, which was not going to be sufficient for a 28-week baby. So I decided to call the Salima District Hospital to see if we could transfer the baby there. And I remember the person on the other line was like, oh, no, like that's a miscarriage. Like, you know, we don't consider that. That's just a miscarriage. Tell the mom that she has miscarried because there's no, you know, abilities to do anything else. And so, you know, once I realized that, all we could do was, you know, wrap the baby and give it back to the mom. And, you know, so I was just sort of watching the mom kind of mourning and crying, and the nurses, you know, surrounding her. And, you know, later her family members came, and they usually bury babies that don't even make it out of the hospital in like these unmarked graves, because, you know, to the village, these are kids that actually never existed except to their mother. You know, and then fast forward, as I'm watching this great, you know, grieving mother, I'm remembering not that long ago, I also had gotten a distress call from now my sister, who's Malawian, but was attending school here in the United States. She's living in Kansas City. She's 28 weeks pregnant. She has placenta previa, and she starts bleeding very heavily at 2 o'clock in the morning. And I remember telling Mabel, you need to rush to the hospital right away. And of course, she gets to the hospital with a 28-week pregnancy. They do a, you know, emergency C-section. And, you know, Emma also weighs a little over 2 pounds, just like that little boy. She was tiny. She couldn't breathe on her own. But the difference with Emma and this little boy was that when she was delivered, there was an entire team of neonatal intensivists in the delivery room. They took Emma as soon as she was delivered. They started IV lines. They had feeding tubes for her. You know, she was placed in the incubator, and for this several weeks she was taken care of, and she survived. And so, you know, today, there's Emma. She's quite feisty, and she is 4 years old now and has a lot of opinions. And she makes sure that everybody knows her opinions. Sometimes I kind of miss the days when she didn't have as much vocabulary. You know, as I look at these two situations, and I'm looking at this mother in Malawi grieving, holding her sweet boy, I wondered if, you know, she had the same access as Mabel and Emma had, you know, that had in the United States, what would have been the outcome. And I remember sort of like looking up to the heavens and sort of wondering, you know, sort of what justice exists in these two exact same experiences, really exact same humanity, you know, same level of love of a mother for a child, but two completely devastating different outcomes. And the simplicity of it is, you know, there's one child born in the United States and the other one was born in Malawi. Is one life really worth more than the other? And so, you know, I'm constantly trying to reconcile the experiences I have in Malawi compared to what I see in the United States, and sort of find, you know, what is my place there. You know, a similar scenario, you know, I was again in Malawi at a local district hospital. I was actually getting ready to do a routine gynecological surgery with one of our Urogyne fellows who was there visiting. And as we were just getting our patient on the table, we got called into this little minor room because they had just taken a woman back there who had an emergency. And when I walked in, there was like a lifeless baby that was kind of laying on the side. And then I looked in and I noticed that you could, you know, I always tell like my fellows or residents, like if you hear the sound of blood, that's never a good sign, right? So you could hear blood flowing. And I knew at that point that something was wrong. So the clinical officer just showed me, and I could see a Foley bulb sticking out. And at that point, I was aware that there was a ruptured uterus. And when you looked, it looked like a bomb had gone out of this woman's pelvis. And she had such horrible damage that we didn't even know where we would start with a repair. I remember my fellow Nadia looking at me and saying, well, you know, is there any other place that we could send her? And I looked at her, I said, you and I are where they're sending her. So, you know, what we're going to do is you and I are going to clamp, we're going to cut, we're going to tie, you know, we're going to keep working until either the divine sees it fit that this woman lives or she dies. You know, so, you know, as we were getting ready, you know, we were informed very quickly that, you know, her blood pressure was very low. And they were also telling us they had no vasopressors. We were in a room that had no lights. The blood bank was also empty. They were actually trying to identify relatives that could come in and donate blood. And so we started a procedure where the patient had already lost so much blood without any resources available, you know, with us. And so, you know, we continued to work. And luckily enough, she actually survived, and she left the, OR with a very low blood pressure, and her hemoglobin was 3. And as we were leaving the hospital, she still, did not have any blood available to her. She was admitted to an unmonitored mattress, essentially in the postpartum floor, where she's now laying next to women that have delivered babies, and they're breastfeeding their babies, and hers is dead and her uterus is gone. And, as I was leaving the hospital, I really was not sure that we would find her alive the next day, because up until this point, there was still no blood. Nadia and I both were not matches, so there was not anything that we could do. So the next morning, I sort of remember walking in very slowly and hesitant, because the part of me that wanted to accept it, that would actually walk in there and she will be dead. I told myself it's fine, she's probably dead, but I also didn't want to really confirm that that was the truth. And so when we actually turned the corner and looked down at where the mattresses were, there was our patient, and she was still alive. Believe it or not, she still hadn't received blood. And I remember, because we had repaired this bladder with no ability to know where her ureters were, and for my medical colleagues, I remember when I looked at the Foley bag and there was urine, actually, that's when I started to cry. I wasn't sure if I was relieved that she was alive, or they actually managed to do the surgery without bagging both of her ureters in a country where she was not going to be able to get dialysis. And so, she reached over and she was grabbing Nadia's hand, and she could barely speak. And I remember her uttering the words "Zikomo," which is, thank you to Nadia, for the work that we had done. So it was miraculous to see her alive. But I also remember realizing that we had just now committed this young woman who, is, married off as part of what takes care of her. But now we're sending her home to her husband, who probably wants children, no matter how we feel, this is cultural, and is now going to go home as damaged, and one that's probably not going to be able to give her husband children, and he could very well choose, to leave her. And so that, the mix of emotions associated with that and what her life was going to look like. A week later, I had flown back to Houston. I was in my bed at 2:00 in the morning. I got called again for something similar. It was a postpartum hemorrhage. I walked in, and, the patient, don't get me wrong, was in danger. There was a lot of bleeding. And I remember walking into the operating room, and I was suddenly aware that this patient was under general anesthesia. There were vitals being monitored on a huge monitor. I could see her blood pressure. I could see her heart rate. And there was this beautiful thing called a massive transfusion protocol, which means there's units of blood and blood products that are basically coming into the room, and they will keep coming until we tell them that we don't need anything else. And I remember everybody was like, "Oh, we're so glad we're here." I was like, "Oh, no, it's fine. I mean, we have lights, we have electricity, we have electrical cautery, we have blood. We're going to be just fine." It was such a different experience being able to do the exact same thing that I had done in Malawi a week ago under these circumstances. And we were able to work on this woman, completed the procedure. She was transferred out, went to the ICU, where she was, monitored, and was able to leave healthy, as well as, go home, with her baby. Where I think I got lost. What is the next picture? Oh, okay. So, one of the things that we talk about in Malawi is, when a woman is pregnant, they call them, women in between. It's a sad term, it's called Maiwabakadi, because really, when a woman is pregnant in Malawi, they're literally considered women that are between life and death. And so, because the reality that women die in childbirth is very clear. And next slide. And so, this reminded me a little bit when I was in residency. I remember I got a call, and there was a woman that was 32 weeks, and she had actually a ruptured aortic aneurysm, and she was bleeding and dying. And I went to the ER, and I had a whole team, and I remember doing what was a perimortem C-section in there. And the cardiovascular team came in, and they put towels in her belly and actually wheeled her to the cardiovascular unit because they were able to get a pulse back. I actually went and observed them, and they put her on bypass, repaired her aorta, and 7-10 days later, she was walking out of the hospital with healthy Ethan. And several years later, she actually showed back up and she was trying to get pregnant again. And I don't think I could have stayed no fast enough. Next to that picture, you're seeing, Ari, that's Joni's daughter. She's actually, visiting Jennifer. Jennifer is 8 years old. Her mom had preeclampsia. They didn't have magnesium sulfate, so she ended up having seizures and, passed away. They were getting ready to actually wheel her to the morgue when they looked and realized that Jennifer was still moving. So somebody ended up doing a C-section and, got Jennifer out, but she has, cerebral palsy. And basically lays pretty much most of the time. We have some chairs that she sits in, but she's not able to walk. She's pretty much going to live with us for the rest of her life. So I see these miracles where on one hand, you're repairing somebody's aorta and they walk out, and then I go back to Malawi and I see children dying from severe dehydration. So what are we doing now to build capacity within the country? My medical. The key here is to build basically well-functioning healthcare centers. And, these are going to be places that are going to provide and enable an environment that has sufficient human and financial resources, essential drugs, and necessary equipment for us to be able to do what we do. Our goal is to really teach our local staff. And one of the things that we do is actually teach obstetrical emergencies and how to deal with them. We have ultrasound technology. We literally have a Lumify, which is a probe that you can buy and you can put it on your iPad or iPhone. And we walk around with that. And that thing is used for just, we found appendicitis. I just started scanning things now that I don't scan. I've figured out what a normal liver looks like so that when it doesn't look normal on ultrasound, I can actually tell. Because I just thought, just start scanning. And then soon enough, I know like what should be on the spleen and what shouldn't be there. And, so we essentially use this for it's like immediate diagnostic tool that we use because often X-rays, CT scans, MRIs, those things are not available. And so teaching our local staff to be able to do that when we do surgeries, we're not just going there and setting up, surgeries. We want to be able to train the local staff. And so that's me with some of the clinical officers, teaching them how to do a hysterectomy. And same thing on the other side, because the goal is when we leave, they need to be able to continue doing these procedures. We do neonatal resuscitation courses. We had a neonatologist that came because often when babies are born and they're blue, they just sort of figure that's the end of it, by just teaching the processes on how you can do, help babies breathe. We actually, after Naomi's mom died, it really motivated our desire to have an ambulance that will be available to transport women to higher levels of care, a waiting shelter as well, where mothers could come in early so that they would have a place that they could live that's very close to the hospital. They can go into labor and just come right into the labor ward. And we're now building the surgical center. Again, this is to increase their surgical capacity. We'll have 4 operating rooms. And so if we add the one that they have at the district hospital, that gives us 5 ORs, which is a huge, step forward. Alaska has been really big in the involvement of this part of the project. And so it was, in fact, the design, we were doing this on a small piece of napkin. It came from the surgical center of Anchorage. And then we just basically, modified it from there. So Dr. Joni Hope has been, fundamental in helping with some of the fundraising efforts. I've come here many times to do the fundraising events. There's been several Kilimanjaro climbers for fundraising that have actually come from here. We also have built this amazing relationship with Alaska Medical Missions because they actually collect medical equipment, drugs. And so often when we're going on the trips, we're able to collect that there. But as we're building the surgical center, they're in the process of actually collecting equipment that will be shipped from here onto Malawi. And, so our goal is we're going to create surgical teams that have been going so that way we actually have people that are going every 3 to 4 months versus in the past where we've just had like one team go just at the summertime. And so we'll try to build teams that have all the different specialties in it. That's okay. So I'm trying to remember. Yeah, this was us breaking ground in the operating room. And then we have our team that's working on the ground on it. Our architect, actually, I call him the unicorn architect. That's Mark in the corner. He is from Kentucky. But several years ago, he actually was given a project to build an operating room in Zambia, which is right next door to Malawi. So he's actually worked under the exact same conditions. And so I met him at a medical conference, and it was almost like, you know, because we had gotten the grant to start building the OR, but I didn't really even know how we were going to start it. And when I was there, he was one of the speakers at the medical conference, and he was talking about when he built the operating rooms in Zambia. It's literally a 4-hour drive between Zambia and Malawi. So as soon as he got off that stage, I found him. And we showed him the napkin. Literally, I gave him the napkin that we had drawn at the airport, and that's how we started this. So Mark is a really gift, and he's doing all of it pro bono. The beautiful thing is Mark actually trained Bupe, who's Zambian, who's over here. So Bupe is actually the project manager. He's the one on the ground, Zambian, doing exactly what Mark had to travel and live in Zambia for. He doesn't need to go live there anymore. He can just let Bupe do it. And that's the gift that keeps on giving. And so, you know, what are some of the things that you can do to continue to work to create capacity is where you have to become very innovative. So I realized very quickly that I was not Oprah. And I couldn't just invite a few of my favorite friends and they would give millions of dollars to a project and I could get it done in like 2 years. Like, what's the deal with that, right? And so, you know, my favorite friends are just trying to, you know, make it by the day. And so I met a friend of mine, Mike Novolio, who you see there. He was actually climbing Kilimanjaro to raise money to provide clean water in Malawi. So he was like, hey, I can give you a platform for this. And so I'd actually never climbed anything. I mean, again, my life was like growing up like in a camp. I didn't feel like camping anymore once I'd been living in the United States. Like, I like the hotels, I like the beds here. And so, you know, he's trying to sell me the idea of going somewhere very cold and, you know, sleeping in tents. But what this does, you know, I don't know why, but somehow I think when you tell people you're about to kill yourself to get their checkbooks, they like write the checks, you know. And so once I told people that I'm going to Kilimanjaro, and it was like, for what? You know, and then, you know, I'm trying to raise money. You know, the response I received from that was remarkable. And I'm forever grateful for Mike because he gave me sort of, you know, that platform. And then since then, I've taken 7 additional trips with people that probably would have never thought of going to Malawi or would have never thought of climbing Kilimanjaro. But it's like sort of, you know, the cause paired with something that's adventurous, you know, attracts a lot of people. So people pay for the trip and then they just raise money from their friends and family who wouldn't donate to me, but will donate to her because she's climbing. So by, you know, the association, we end up sort of, you know, multiplying what we're able to get. This has been very successful. That's actually been the way we've been able to support all the, you know, medical causes. So I'll be heading back to Kilimanjaro, and Dr. Carol Williams is joining us. We actually have like, what, 6 or 7 people from Alaska who are coming. There's a whole group of ski moms. My friend Nancy, who's the ER doctor, Natalia, who is over there, who's one of the OBGYNs locally, and they're all joining. So we'll do Kilimanjaro, and then we're going to go to Malawi to do the medical surgical work. And I was thinking, I think I'm missing a page. So there's a page that I'm missing. Yeah, I could probably look at that. Sorry about that. So, you know, often when I look at my life, you know, oh, that did not go well. It's filled with a series of people who have used what was in their hands to fulfill, you know, a higher purpose. My parents' selfish love, you know, while I was telling my dad, I'm never going to marry a guy who wants to be a pastor and go live in a village. At the end of the day, that's also what has taught me to also take the road less traveled. You know, they're often the burden of carrying this particular mission is overwhelming. There's a lot of weight I feel on my shoulder. There are times when I actually wish I was less responsible. And I ask myself why, like, why take something like this on, right? You know, I don't have all the knowledge, all the skills, and really, you know, no real, you know, big $1 million financial base. But somehow it's always people that I meet along the way that actually make this project happen. Donna, she used her financial resources and access to higher education in the United States. Mike shared his Kilimanjaro dream to kind of help me to fuel my own dream and be able to empower what I was doing. healing. So even though life takes us through different seasons, sort of like a little bit of what, Dr. Williams, talked about, is that, you don't have to worry about what you think you can and you cannot do. Sometimes it's just to be courageous and to be thoughtful and to just be willing to stretch yourself and to see what you're able to be, to do. And so suffering is a very difficult concept to be able to accept and to reconcile. There are millions of people that are unreached. And millions of people that feel forgotten, and they face injustice and inequality. And this even happens in places where we work. We really, as physicians, have an incredible opportunity and platform to hear the voices and to be able to open our eyes and to, see people like this. Okay. So, I always say this, you could be the person that gets to build a school in a village, in a community where they never had one. Or you could be a person that would bring a meal to a family that was praying for one, like we used to. And every now and then there'll be somebody that would show up with a loaf of bread. And every little thing that we give of ourselves actually can make a difference in somebody's life. And so my story could have ended up in the village, as many stories of children like me did, but it brought me so many miracles that were delivered to me by ordinary people who literally decided to do the extraordinary. Donna is a white woman who lives in a very tiny, town in Texas. There were no Black people there when I moved there. I was it. And the bravery of her, finding a young girl she had only known for about 2 weeks, into her home to live with her children, and take her to a community that was unfamiliar with, a person like me, took a lot of bravery. That's an extraordinary action from a very ordinary woman from a very small town in Texas. And, my childhood experiences in Malawi were part of the foundation that actually has defined and makes me the person that I am today. So in the voices of these wailing mothers and that losing their babies, or the tragedies that I see of the young women who are dying, giving birth, instead of me seeing this as just a desperate situation happening, what I did here was, who shall I send and who will go? And, regardless of what I think my inabilities are, I made a conscious decision that my answer is always going to be, here I am, send me. So this is now where we are with the operating room. We just got this picture, was that last week? And so the goal is this will probably be finished by at the end of this year. So we'll probably start doing the C-sections immediately after. So the birthing center is actually here. So they're going to wheel the women directly into the OR. The first one will be just for the C-sections. We're going to have a lab. We have a blood bank. We have some radiology services. So we're excited that probably 2025 trip, this is where we're going to be operating. And I think Joni and a few people have like a fundraiser that's set up for April here that's going towards equipping this with equipment that will come from Alaska Medical Missions that will go in and fit into that. All right, thank you very much.
They were going to ask questions.
Does anyone have questions for Dr. Alanis? That was fantastic. Thank you so much. Truly amazing.
It was beautiful. I was wondering how you keep your spirit high it almost seems like starfish on a beach and you're making an impact, but it's just so overwhelming. How do you keep yourself optimistic and hopeful?
Yeah, I was talking about this with someone earlier because, I remember the last time I was in Malawi. So the first story I shared about the postpartum hemorrhage happened probably, 2 years before. And then, last year I was there with a different fellow, and I got called into the same room like for the exact same situation. And I had this moment, like, how long? And like, what are we actually doing? Because it was like just this sort of fresh moment of like, how do I keep living this experience like over and over, And so there was like a moment of desperation that set in. And I remember sort of leaning on my knees, and Dr. Lindo, the urogynecologist, was there, and she just sort of came to me. She said, we're making a difference. So we're going to take a deep breath. Let's go in there and help this young woman. And we did, and we finished that, right? But out of that is also where the dreams of what do we need to do to change that? That's how the operating room, became a dream. Joni is the best person to kind of dream about money. I'm always aware of what I cannot raise. And she'd be like, let's raise $2 million. And I'm like, yeah, I'll let you say that. You know what I mean? So even if we don't raise, so we started sending out, we just solve one problem as it comes, so I try not to look at it so big, because I think sometimes when you do that, it can be overwhelming. And I've seen people being paralyzed by the amount that needs to be done, that they do absolutely nothing. And I've been there where I'm asking somebody for help. Like I remember once asking a missionary, because there was a baby that someone had thrown into the toilet because, it was too much. They couldn't, but someone heard the baby, and so it got dug out. But there was nobody to feed the baby. We took it to the grandmother. The girl that had delivered had run away. And so I remember our family going to this missionary home and asking, is there any way you can help us find the funding so that we can actually buy formula? Because the grandmother is not going to be able to do it. And then they were like, well, but there's 20 other kids in that village who don't have formula. So if you're going to buy formula for this one, then we're going to have to buy formula for everybody. And there's not going to be resources to buy formula for everybody. So don't buy any formula at all. I think sometimes if you think that way, you're not going to move at all. So I just try to see like the immediate problem and what are the solutions. And then to really be honest with you, I think, the friends and the people that God has just sort of brought alongside me, that I feel they're just like divine intervention. Anything that I'm incapable of doing, somehow the universe, God, whatever you believe, brings me the person that has that strength that I don't have. And I feel like most of this work is other people really lifting me to have any capacity to do it at all. And that's what keeps me going.
Anyone else have any questions?
And by the way, we have a lot of Malawi here,
Yeah.
believe it or not. So there's Wezi over there with her son. And so she's actually from Malawi. So when I came here the first time, I was actually surprised at how many people actually, so that's why the whole geographical location of Malawi and Madonna was just flat here, because most people actually know where it is. And so there's a whole community, like she's involved with some of the work that happens at the Children's Village in Mangochi, where Annie, our registered nurse, who's our charge nurse in the OR, in the maternity ward, works. And quite a few people here have been to Malawi.
True story. This fall, Annie came to New York. Oh, you want to say something? Okay. I'll tell you, but I'm going to give this to you. So Annie came to visit in New York with her sisters. And I was like, well, let's do something fun. And it just so happened Madonna was playing in Brooklyn. So I got 3 Madonna tickets for them, which is totally outrageous.
Yes,
We found ourselves at a fundraising
Yes, it
event,
was.
like a fundraising lunch, the moment they hit the ground with a friend of hers. And he's like, well, I don't know if this is going to work. And she takes a selfie video with Annie and her 2 sisters. And he's like, just talk about, Malawi. And so she talks about, hi, I'm a doctor, and we're going to go see Madonna. Within an hour, that video had gotten to Madonna. And we got backstage. We met all of her children
Yes.
and invited her to come to Pothawira this summer.
I don't know if she's going to make it, but we tried. Yeah. So we actually met all her Malawian kids, the twins. We met Mercy James. We met David, actually sat down. I mean, we got like VIP tickets. I like, what is going on here? Like we walked in there. So we had our own entrance. So, remember, I'm from Malawi. So these things are like, just walking through a separate door, like, we know who we are. We had the, special tags that were on hold for us, and we were able to get to this room. But it was just really just being able to sit with the kids even and talk to them about, the work in Malawi. And, David, the oldest, I mean, he was, he's very involved with the work that they do at Mercy James, which is the only pediatric hospital in the entire country. And that's what, was built through Madonna's foundation. And, just even talking to him, and I remember at some point, he raised his hand, to sort of high five me, and he says, we need to be part of the change that we want to see in Malawi. And for a kid who's really spent most of his life here, and I was really proud just at that moment to see that his life is so big, but somehow, he's managed to still remember. So the show was insane. I think my sisters are traumatized for life. I've been here long enough to be okay with, some of the bedroom scenes that were on the stage, but I think my sisters will never be the same. But I blame that on her.
Annie, thank you for being here, and thank you everybody for being here as well. It's working. Is it working? Can you hear me all? Yeah. Okay. I just want to say I'm inspired by what you're doing, and I do have a question, and maybe it's more of a comment that you can add on, the healthcare disparities, in terms of cervical cancer screenings, pap smears. Here in the US, the new recommendations, the new guidelines are that, we should start doing the pap smears at the age of 21, right? And then, you keep doing them 3 years and then 5 years. But in Malawi, what are we doing?
Yeah. So unfortunately, Malawi, that's way behind. So the most that they do for cervical cancer screening is they call them VIAs, which are visual inspection of the cervix with acetic acid. Or they sometimes do it with Lugol's, which is just a different way to be able to assess for any high-grade lesions. And so they come in, and depending on the level of skill that the person that's doing that procedure, they may or may not be able to actually find the high-risk lesions. And the other limitations, the last time I checked in Malawi, so there's 18 million people, there were 3 pathologists in the entire country. You have to pay $25, which does not seem like a lot of money to get your pathology read. But when you're making $1.25 a day to feed your children, you're probably, for a suspicion, probably not going to pay $25 to get your biopsies looked at. So we have seen largely advanced cervical cancers in Malawi, and even patients with 1B disease are disposed to hospice because they don't have, hardly any trained GYN oncologists. The people that are there are usually expats that are visiting, and there's no radiation services unless you can afford to go to India and get radiation. So this is actually one of the things we're planning on addressing. When Joni climbed with Ari, they actually were raising money for, you want to talk about that technology from radio?
Or
Yeah.
HPV testing, and then see and treat cryo.
Yeah.
And thermal ablation
Right.
technology,
Yeah.
so that we can treat immediately once you figure out who has high risk HPV.
Yeah, so we're going to incorporate that into the work. And, part of the way we're designing the surgical center is also to be able to sort of tag on and probably build, cancer services. Chemotherapy is almost non-existent. One of the best parts about getting a rejection that ends up being some kind of an elevation was we had applied for a grant to Direct Field because somebody had donated $75 million to healthcare disparity. So I was like, well, what's the place that's more, has more disparity than what's going on in Malawi? But the donor stipulation was that that money would only be given to American located facilities. And so we were rejected. However, we were then directed to the women and sort of like pharmaceutical side of what they did. So we actually now have this amazing relationship with Direct Relief based out of Santa Barbara, where they've, shipped like $1.5 million worth of drugs. They actually have chemotherapy drugs on their list. The last time I was in Malawi, I did a mastectomy. We had to call a breast surgeon here to find out, because it was a woman who had a breast cancer that nobody was able to take care of. So did a mastectomy, and we're actually able to get Cytoxan orally from Direct Relief that she's actually receiving now. So I think as we develop, processes around that, I think that's a goal to try to say, I think getting the vaccine there would be amazing. Like, I think we need to vaccinate for HPV.
Any other questions?
Hi, I'm wondering if on the website, there's information for any folks that might be interested in volunteering.
Yes, we usually have information about like trips or just how to contact us if there's anything in particular. I think because of the nature of what we do, it's very multifaceted because like part of the idea of this facility was to sort of address the multi-layered nature of poverty because even if you provide healthcare, how do they get there? If the kids aren't educated, they're not going to have, access to education. So, changing that story, has multiple layers to it. So we've had people that have come and we had somebody that came, a retired English teacher and spent 8 weeks doing sort of like an ESL training with the teachers and actually doing English classes with the kids. So Malawi is a British colony. So all the schools are actually sort of like a British-based educational system. So by 5th grade, all their curriculum is in English. So you're taking kids that speak predominantly Chichewa at home, and by 5th grade, they're supposed to be speaking and understanding English well enough to be able to take their exams in English. So, even that was a gift for us to have.
Thank you. Thanks so much for the presentation.
Thank
That's
you.
wonderful.
All right. Thank you, Dr. Alanis, and thank you all, everybody.